what I'd like to achieve a little bit today is a little bit less of a didactic lecture style format. We have a relatively small group, so hopefully it can be interactive and learning from each other. You'll see as we go through that one of the things about, well, myotonic dystrophy in general, but certainly about the pediatric and congenital aspects, is we don't have very large studies to say, oh, this is a very definitive aspect of it. And so we do need to learn from each other and discuss and network with each other. So I thought what I'd do is walk through a little bit the life of a child with congenital DM1 and pick out some of the more significant issues that I think we all grapple with. Hopefully there are things that you guys are interested in as well. But if not, we can certainly shift focus and willing to take thoughts or comments from the audience as well. You know, here are some of the things that I thought we could touch down on a little bit. Things like birth, pregnancy, and planning. The diagnosis. Already, you know, people have come up to me and talked a little bit about what exactly that is. Talk a little bit about ventilation and some of the things that we've been looking at in our group in terms of ventilation. Development, and I've put here, you know, this issue of autistic features, and I'd really like to get a lot of your thoughts as we go there. And then I have a bunch of slides on things that, you know, we do or recommend or consider in the management of various symptoms and problems that kids can encounter with myotonic dystrophy. And again, we probably won't get to a lot of those, but I'm happy to, you know, for us to kind of go through any of those aspects, and you'll see I have lots of slides. One thing I might mention too, just to go back a little bit, is aside from our group, one of the groups that I work with quite closely is Dr. Nick Johnson in Utah, and so I'm going to show some data as we go through from studies we've done together. The other thing that I'd love to get your thoughts on, because we're doing a lot of more qualitative work in this area lately, more in spinal muscular atrophy, to be honest, but I think it has particular relevance for myotonic dystrophy, is this aspect of decision making. And really, more than decision making, how do we create an environment of shared decision making that help us to, you know, understand the evidence that we have around decisions, which again, I'll be honest, is often very limited, but also link that to, you know, personal preferences of the family, the child interests. And there are tools and environments to do that. They haven't been well developed in myotonic dystrophy, but I think it's really critical. And so I hope later on I'll ask you a few questions about, you know, your experiences in decision making around interventions or therapies or things of that nature, and get your thoughts a little bit. You know, one of the things that I mean, I think you have to talk about when you think about congenital myotonic dystrophy is the birth and some pregnancy issues and planning. And you know, for many people, as you probably know, from many studies we've done in our group, half the time the child is, you know, what we call the index case. And I know that's not it's kind of a cold word for things, but basically it's a term that means that the child is the first you know, person who has myotonic dystrophy in that family, and it sort of starts a whole cascade of you know, understanding how that's run through the family. But some of the time, half the time, it's not, and that's been shown in many studies. It's about a 50% number, and so, you know, again, in that theme that I really have, I hope I should put a little disclaimer here too as we go through a session. Nothing I say here do I want you to go out and say, oh, this is, dogma, we have to follow this? In fact, one of my main things about doing the kind of research we do is to actually really give people the proper information, the accurate information, so they can make a decision that's best for them. So when we talk about ventilation duration and things like that, I don't want to give people the impression I'm, necessarily for this or for that. It's to give people the information they need. And this starts right from pregnancy and planning. I'll give you a little bit of data from a study we did. And this was from about 40 parents, moms in particular, who had a baby with congenital myotonic dystrophy. And this was one of our studies we did in 2005 to 2010. We did various measurements with these families, but one of the things we did was sent out questionnaires to the moms. And I just wanted to go through the two groups. There were certainly a number of moms who knew they had myotonic dystrophy, and in fact had been between 15 and 35 years old at the time of their diagnosis. About half of them, which is really not great, said that they had had specific counseling to explain the risks of congenital myotonic dystrophy when they received their diagnosis. That's very low to me. That's and about 50% had prenatal testing that was offered. Again, I don't have the timelines here, but it's interesting. Then ultimately, no one chose to have prenatal testing done with their pregnancy. Again, but most said that now that they had a child with congenital DM1, they would decide not to have further kids. And about 25% said they definitely would have more children, and about 25% undecided. So I think the key points here that that worry me is that people aren't really even getting the information. Again, that's a theme I want to, I'm not sure families are exactly, and particularly moms, getting the information and getting the kinds of things offered to them that they should have offered. Maybe you can give me some insight into why no one choose that, and that's actually been shown in other studies as well. For the moms who didn't know they had myotonic dystrophy, and they had a child with congenital myotonic dystrophy, 60% said for sure they would have another child, 30% said, I think that's enough for us, and 10% were undecided. And all of these 60% said they would have prenatal testing though. So they wanted to have further children, but they would definitely be aware of the risks around having another child with congenital myotonic dystrophy. So I think those are important. Interestingly, many parents said 80% of the whole group said they felt they had enough knowledge about congenital myotonic dystrophy to make educated decisions. So I'm not sure where they were entirely, because there's certainly a gap here for us. So I guess, one of the questions, and I'm happy to have some comments, is, really, are people getting the best advice and opportunity to discuss about family planning in the setting of a diagnosis, or even having had a child with congenital myotonic dystrophy? Any comments? Or yeah.
Do you think it's more that they're not getting the advice, or that with myotonic dystrophy, there's the executive function problems? So I'm wondering if it's more the moms they're getting the information, but they're making the decision based on their lack of executive function, or if they're not getting the information.
I think it's a bit of both, because what I show here is only 50% of moms could recall even that was even mentioned when they got diagnosed, and that's between 15 and 35. Those are childbearing age ranges you're being diagnosed in.
But that's what stuck out to me, that they were probably juvenile onset themselves. Therefore, their cognitive capacity is impaired.
Yeah.
So
and that might
all
be
the
why
other information
even the
makes
50,
sense.
that's why, yeah, maybe even the 50% who are offered, talked about, aren't necessarily choosing to engage in that. Those may be some of the, that's certainly, I suspect, a big component, but it's still, unfortunately, an information gap there as well. Don't know if anyone else has any experience to share.
Can I just ask how large that study was, please?
I was about 34 mums or so. Yeah. It's not a big sample.
In
no.
one location?
No, across Canada.
Okay.
Yeah, those were across Canada. Yeah.
Personal experience here. I know my wife always wanted to have another child, and even though she had been, after we got Teddy diagnosed and then she was diagnosed, she still even then wanted to have another child. So I think it was more of an executive function thing, but yeah, she absolutely wanted to have another child.
Right. Yeah. Yeah.
Well, I did too, still do, but I'm getting told now, but I need to go through PGD.
Yeah,
So I knew how to
pre-implantation.
prevent it the second time, it just didn't work out for us.
Right.
We went through it, but it just didn't work out for us.
Yeah. And you feel you're getting the proper information about how to do that. Yeah, how to
I'm
navigate
told
that.
I still would like to have
pathway.
another child, but I'm 44 years old now, so.
Right. Yeah.
It's too late for me.
So I think it definitely behooves us to make sure, as we go through the care consideration plans and thinking about, how to disseminate like knowledge translation to physicians that are out there, obstetricians, and that we make sure people, understand about this dynamic that people may need more opportunity, need the information more clearly or repeated more often, or more space to make those decisions, more support in that. So the next thing I'd like to touch down on is really what is the definition of congenital myotonic dystrophy. There's really, unfortunately, no good and uniform definition, and that's something I think we need to work on as well. And I'll, again, curious to get your thoughts, but really, a lot of the time we don't know when someone says they have congenital myotonic dystrophy if they're talking about the fact that their baby had a little bit of low tone and they knew it ran in the family, and so it was identified early, versus someone who was on a ventilator for the first 3 months of their life. Those are often kids who are grouped together. Family history obviously makes a big difference to how you view your newborn. There are many families who don't have a history who would never recognize, and many physicians who would never recognize some of the feeding difficulties, some of the low tone as necessarily a sign of myotonic dystrophy. Right now there's sort of this thing, many people use a cutoff of the presentation of symptoms around a year. Doesn't make great sense to me, to be honest. I mean, that's a much different child who you start to see symptoms when they start to have to crawl and walk and that sort of thing than, again, someone who's on a ventilator early on. And people say, well, why? Who cares really? Does it make a big difference? Why is splitting hairs? And I think it does make a big difference. I think it makes a big difference for you guys. I think it's hard, to really prognosticate or think about the future when a lot of the data we gather is on, if you talk to someone with congenital myotonic dystrophy, they might have a very different child and start to life than your child did. So I think it's very helpful to have a common language around this. I think it's difficult for study and for science. If some of you go to the IDMC meeting, you'll see presentation after presentation, people get up and say, we studied kids with congenital myotonic dystrophy, or we studied kids with juvenile onset myotonic dystrophy. And to be honest, it's often without sort of pressing the investigator in a they might have a 15-20 minute talk, without going up and really saying, well, what are those kids with congenital myotonic dystrophy? In fact, even the scientists in the lab do it. They'll get up and say, we studied muscle tissue from 5 kids with congenital myotonic dystrophy, we don't even know, really who those are. And that's really critical when you start to get to a point like our community is, where we're getting to, potentially drug trials and therapeutic trials. One needs to have this very crystal clear for the regulators. So that's it. And then, of course, physiologically, and that's a term, in terms of body function and that sort of thing, I'm not even sure that that makes a lot of sense, why we tend to have the cutoff for childhood at 10 years and a cutoff at 1 year. So anyways, a number of myself and a number of my colleagues are, sort of trying to refocus us a little bit as a community and hammer this down so we can be more precise. Yeah.
So are they trying to kind of create two different populations within congenital myotonic dystrophy? The more severe that's on the ventilator and then the others that walk? Because really, if you're going to have a study, I agree. I mean, that's two totally different kind of populations.
It's totally different. So what we've done since I proposed this in 2004, and I think slowly people are looking at this as, that we repeated this in our further studies now with Nick Johnson and I, who are really doing most of the definitive work on outcome measures in congenital. We've taken a very strict definition because we feel it needs to be objective and clear. So we really follow the criteria where we say, a child can be diagnosed a little bit later in their life, up to 3 years old, but they have to have had symptoms in the neonatal period that really require medical intervention of some sort. So again, this sort of removes a little bit that low-tone infant whose family already knows about the condition and they get diagnosed right away. Or someone who said, well, my baby wasn't the best breastfeeder initially, but we worked it out. That to me, that's a different group. So we're really trying to make an objective diagnosis here, and we have to have a genetically confirmed child. I mean, I think more and more in our day and age, that's happening. I mean, but if you look back at the past literature, that's not even that clear. And you have to have a repeat size greater than 200. With all the work we've done, the smallest repeat size we've ever found in a congenital baby is about 450, I think. So we've made a lower cutoff, but still not a completely. And then everyone else we're really proposing is called as childhood or pediatric myotonic dystrophy. And forget about this 10-year-old cutoff between childhood and DM1. I mean, my talk, and again, I'd be curious your thoughts, my talking with families is it's very difficult for them to say an age of onset. As soon as they have a diagnosis, a genetic diagnosis in front, most of my families that I interact with say, oh, that explains that and that and that and that, going back a long time. So to talk about age of onset is very challenging in childhood, I think. Yeah, comments or thoughts?
So, I'm sorry, we need all three of those?
Yes.
Okay.
Yeah.
So you and other researchers in Canada are doing this. Is that the feeling internationally?
Well, again, I think, again, a lot of people, and you read a lot of papers still use this broader terminology. That definition actually goes back into the early 80s. Was developed by a person named Koch, K-O-C-H, even before we really had any of the genetic information about it. So it was a convenient way to classify things. I wouldn't say just in Canada. Again, Nick Johnson is in Utah, and there's very few people doing active research in this area, 3 or 4 of us. We're starting to use that. But I think in the wider, even in the wider DM1 community, you might not, I mean, this may be something that we have to continue to work on. Yeah.